All right, hello everyone, and welcome to the Babies in Common videocast, which will also be made into a podcast. I'm Jeanette Messit-Frem, the owner of Babies in Common. I'm an internationally board-certified lactation consultant, childbirth educator, mostly retired, birth doula, and mother of 2 teenagers. And Melissa is here as well. Melissa.
Hello, I'm Melissa Ann Dubois, and I'm a registered nurse, childbirth educator, and lactation counselor. I've worked in all sorts of hospital and inpatient and outpatient OBGYN settings. I'm currently providing postpartum home visits for home birth families and also virtual birth doula services for people giving birth in a hospital during the COVID-19 pandemic. I'm also the mother of 3 small children.
Awesome.
Welcome, everybody.
I'm so excited that you just got into that birth doula work. That was great, a great addition to our community. So, all right, so we have another great episode for you today, but before we get started, a couple of reminders. First, as always, anything that any of us, our guests or participants say during this conversation is not to be taken as medical advice. Please consult your own healthcare professional and related to anything about your babies or your own health. Also, the opinions expressed during this conversation are personal to the host, guests, and any participants, and do not ever represent the views or policies of any current or former employer, including hospitals and clinicians. Our conversations are done on a HIPAA-compliant platform, and for a full review of our disclaimer, please visit babiesincommon.com/disclaimer.
Excellent. Thank you, Jeanette. Now on to our show. Today is May 18th, 2020, and today we'll be doing a 2-part episode. So the first part of our episode is episode 11, and we're going to be discussing breech presentation and external cephalic version, which is a procedure that helps try to turn a breech baby by kind of pushing on the pregnant person's abdomen to get the baby to go into a somersault. So we will be discussing that, and then we are going to have part 2 of our episode is going to be episode 12, and we're going to be talking about positive cesarean birth, or how to have a positive and empowering surgical birth experience, even if that is not what you wanted or expected. And so we are joined for both parts of this episode by Kate Damon. Kate is a certified nurse midwife who works as a full scope midwife, attending patients in the office and catching babies in the hospital for a Cambridge-based practice. Kate received her bachelor's in biological anthropology from Harvard University and her master's degree in nurse midwifery from Yale University. She's smarty pants. So she lives in Watertown with her husband and her 2 daughters. In 2015, Kate had a cesarean birth for her first daughter, who decided to stay persistently breech despite a lot of spinning babies moves, wishing, hoping, praying, and even 2 external cephalic version attempts. She was a stubborn little girl. We will be discussing how she made her cesarean birth a positive and empowering one, despite it not being the birth experience she had originally hoped for, and how she advocates and facilitates a family-centered cesarean experience for patients in her midwifery practice. So thank you so much for joining us today, Kate.
Thank you so much. I'm excited to be here.
Yeah, thank you. All right. I love that you're a care provider who had this happen to you, and it's such a different perspective from the inside, as well as stepping away from that professional side and realizing how it all was just as a person, a human, a mother, you know?
Yeah, I kind of joke with some of my friends. I imagine there's like a birth bingo board with all of the different I'm getting so many stamps. There's like, you know, Pitocin, got it, Terbutaline, got it, breech, bingo, you know, like version, C-section, VBAC. And so I'm pregnant with my 3rd, and we're going to try to get some more spots on the bingo board.
I love that. That's cool. So yeah, let's start with that. Let's start with your pregnancy, Kate. You are a midwife after all, and so labor and birth are your areas of expertise, but it is totally different when you are the patient. So how did you prepare, you and your partner prepare for labor and birth during your first pregnancy?
Sure. So let's see, I talked about things a lot with my partner. That was back before we had kids, so we had a lot more time to talk together. And we processed things, we discussed preferences, and through our conversations, I kind of gave him a bunch of information, which is basically what most partners learn during a childbirth ed class. I knew I didn't want to have to think, so to speak, during my own labor, so we hired a doula to help us both. And then, of course, we did some prep for the baby, which when I think back on it, you know, it's just plain comical. Like nothing can actually prepare you for having a baby. And of course, each baby is so unique. So most of the preparations we made for that first baby were completely scrapped in the early months. But yeah, I mean, I tried to separate my professional way of thinking from birth, and try to compartmentalize that, and then tried to keep this separate because this was us planning for our family. Yeah.
So Kate, when you were thinking about your ideal birth experience, you know, if you could have what you wished and hoped for, what was your birth plan?
Yeah, I mean, I think I had healthy respect for the birth process, and realized that so much depends on circumstances. Oh, and really, I mean, it just depends what kind of labor hand you get dealt in labor, right? And so I knew I would need to be flexible, but I did go into pregnancy hoping for an uncomplicated, unmedicated vaginal birth, and trying to, and I tried to remember that most births are normal, uncomplicated vaginal births. And so I just thought, well, statistically, chances are hopeful that that will be me as well.
When you think of that kind of thing, were you thinking of physical ways that you were preparing for that? Like, were you doing yoga, like stereotypical things? Were you sitting in certain ways to, like, what did you know at that point about getting ready for an unmedicated, uncomplicated birth, as far as like baby positioning or just using your body in pregnancy in preparation for birth?
Yeah, you know, I wish I had done more with body mechanics a little bit earlier. And I think that when I'm not working, I have pretty decent body mechanics, but I was surprised that it's interesting. I think as someone who works in labor and birth, we so often focus on the inpatient side of nurses and body mechanics. But for me, it was actually tricky when I would work in the office 2 days a week, because I was sort of kind of like hunched or crooked over a computer at funny angles while talking to patients, and sometimes with a phone. And I would come home from those office days actually realizing, like, I've been slouched in a funny position and my back is hurting. So, and you know, and that's a tricky one to troubleshoot because you still have to do your job. But I do wish I had done more with body mechanics earlier, but from the point when I found out my baby was Breech, which was around 28 weeks, then I did focus quite a bit on positional exercises and body mechanics and those types of things.
So you found out around 28 weeks, and how did that feel to you emotionally? And what did your provider tell you at the time?
Yeah, emotionally, I think initially I was a little bit surprised. You know, thinking back on it, I should have realized, you know, like I was like, gosh, this baby's bottom is so rock hard. It just feels like a head, you know, like, but again, it was that disconnect between being a provider versus being a patient. But so when my midwife was like, oh yeah, that baby is Breech, I was a little bit surprised, but it was 28 weeks. So I was just all business. So I knew that most babies who are Breech at that point in pregnancy will spontaneously turn themselves to be vertex, which is head down, by full term. So I just set out to do all the things I could to help the baby turn, which was quite a lot. And I just sort of, I tried not to put the horse before the cart at that point. I was just like, all right, well, what I've got to do right now is get this baby to turn. So that's what I'm going to do.
You're right, Kate, when you talk about, you know, taking a big deep breath if you find out your baby is Breech earlier in the pregnancy, because there is a lot of time for the baby to turn. So just to talk a little bit about statistics, 25% of babies are Breech before 28 weeks. And that's because that little small fetus has a big swimming pool to kind of swim around it and get in lots of different positions. So that's 1 out of 4 pregnant people is going to have a baby that's Breech before 28 weeks. But by 32 weeks, so only a month later, only 7% of babies are Breech. So most of them by that point have turned head down. And then by full term, 37 weeks-ish, about only 3 to 4% of babies have stayed persistently Breech. I joke in my class, you know, most babies by that point have gotten the memo that they need to turn head down. And some babies don't turn head down down because of some maybe mechanical reason, like perhaps the mom has a heart-shaped uterus and the baby's kind of stuck up on one side of the heart, or maybe the baby is wrapped up in their cord and it's not causing them any distress, but it's preventing them from turning. And sometimes we don't ever know why the baby is breached. There's no obvious physical reason. And, maybe the baby just forgot to turn head down off chute. And then now they're stuck in that breech presentation. So I do also, as well as a labor and delivery, office nurse, whatnot, when, clients, parents, patients tell me, oh, my baby was breech at my appointment. If it's, still earlier in the pregnancy, I try to be very reassuring that, it's likely the baby will turn. You don't start panicking now if that wasn't what you were hoping the baby would be in. But there's kind of a issue, I feel, and I'd love you to speak about this as a midwife, but too often I hear from expecting parents, well, the doctor told me not to worry, there's nothing I need to do about it because 97% of babies will be head down by full term. And while I understand don't freak out because there's plenty of time to turn, to me, waiting till 37 weeks to start trying to think about convincing a baby to turn or making a lot of extra space so the baby can get into an optimal position for birth is really wasting some valuable time. So how do you counsel patients if they found out their baby's breech at, 28, 32 weeks, whatnot?
Yes. I couldn't have said it better myself. Exactly. I don't want them to be stressed or nervous about it. And of course, everything has to be the right fit for each family. So with my first pregnancy, I did everything under the sun because I had more time. I had more bandwidth for a million appointments. So early on, I got set up with a chiropractor who was trained in the Webster technique. And I don't remember the schedule, but it was maybe like twice a week or something that I was seeing that chiropractor. And that's what they would recommend, very frequent adjustments to have the optimal outcome. And same thing, acupuncturists, we hear this all the time. Someone will go to an acupuncturist at like 40 weeks to try to induce labor. And the acupuncturist is like, I am willing to give you my services, but this would have been more effective if we'd been doing this for 8 weeks. And so I agree. So I will say, as an aside, my second child was also breech for a period of time. And it was interesting because then at that point, I was just like, this is not going to be the right thing for my family, for me to go to all of those appointments and do all of those positional exercises. And I think I also had begun to think, if this one's also breech, maybe there's something about my pelvis, the shape of my pelvis, that is prohibiting a baby from getting into a head down position. So anyway, just as an aside, but yes, I agree. If someone wants to turn the baby, which, most first-time moms do have a little more bandwidth, and again, depending on insurance coverage and all sorts of things, or have the time to do the perfectly free positional exercises at home, then I say starting them early, like 28 weeks is great, 28, 30 weeks, something like that. Certainly earlier than that seems like overkill. Like if you find out your baby's breech at the anatomy scan around 19 or 20 weeks, I would say, whatever, it's still flipping and swimming, don't worry about that. But getting into the start of third trimester, yes, I think there's nothing to be lost from positional exercises. And yeah, makes a big difference.
Awesome. So you mentioned a couple things already that you tried to use to turn the baby. Acupuncture, Webster certified chiropractic care, which if anybody is interested in chiropractic care during pregnancy, which there's so many benefits, not just if your baby's breech, but ICPA for kids is a great organization, the International Chiropractic Pediatric Association. Webster technique is the technique that chiropractors who have specialized training in the care of pregnant women and babies undergo. So that's what you had described you had done. Is there anything else as far as positioning?
Yeah, definitely.
Try?
So I did a lot of positional exercises. So those were things. Now there are great websites that diagram how to do these or have videos. So the Spinning Babies website is a great one that we refer a lot of people to. But I did a lot of the forward leaning inversion and the breech tilt on an ironing board and open knee chest. And those are the big ones that I recommend to patients too. And those are all things you can do at home. The breech tilt, you do need something hard and firm that you can prop up on something like a chair or a couch. But like I said, an ironing board works, or most people have something at home they can use to just position, just a hard, flat, long surface. I was surprised these things are a little bit harder than I would have guessed when you're pregnant. So I had recommended these things to patients before, but then I think the combination of I had like pretty mild heartburn in pregnancy, but just like a touch, but then when you're like constantly inverting yourself, and then the increased blood volume of pregnancy, I made just every time I did one of those inversion exercises, it was, I felt like my eyeballs were going to pop out of my head. And so I was surprised that those exercises, we recommend them to people. I still recommend them to people, but but it's it's an ask for someone to do these. These aren't just, it's different than just light stretches. They're a little bit harder. Yeah. And then I tried to,
Are you familiar with the fact that Spinning Babies has Spinning Babies parent educators to teach a whole class about that?
The Aware Practitioners course?
No, that's different. So there are parent educators, and there's only 3 of us in the whole state right now, and I'm one of them. And
for
so
childbirth ed classes.
Yeah,
Yes,
it's very specific to that. So where, someone goes to a website, like you're saying, like you look at a picture and sometimes you think you're doing it right, or it doesn't make you feel right. And there's so much more information that we can customize to each person and look at their body and talk to their partner about how to support them in that position and help them by doing those positions. So, it's an option to add to that. And I definitely encourage people to take it early on, because there's also so much information included about how to, even starting at 20 weeks of pregnancy, you can do different activities throughout the day that help you feel better and maybe even prevent the baby from getting into the breech position in the first place. So it's like an added value to that, especially if people are finding it challenging.
Yeah, those are great. And I believe, I haven't checked their website too recently, but I think they have a video link for the daily exercises that someone said that right on their website, someone could start there too, even earlier in pregnancy. Yeah.
Yeah, just like general, stretches or small exercises that any pregnant person can do to help their body feel the best. I recommend Spinning Babies to everybody with a baby in their uterus, honestly, because it's one of those, if I had known then what I know now, maybe my first baby would have been OT for 27 hours of labor, definitely something that anybody who's pregnant should check out for sure.
Yeah, definitely. Oh, and so then I just wanted, there's all the positional exercises for sure. And then I tried some of the other things like having appealing sounds low near my pelvis. So familiar voices. So I would have my husband, talk to the baby low in my abdomen. Although as I was doing that, I was always like, he and I would end up having a conversation, and I was like, maybe he's hearing my voice up here. And don't all babies hear their mother's familiar voice up here? But we would try that, or we tried playing music low in my abdomen, or putting something warm like a gentle heating pad down near my pelvis and something like an ice pack at the top of my abdomen. So trying some of those things, and then just sort of visualizing the baby turning, and kind of trying to encourage the baby, when you're checking in with your baby and growing that connection with your baby during pregnancy, just kind of checking in and being like, hey, like, we're going to try to do this together. Like, how about you try to turn today? And then I also spent a lot of time at the pool, which luckily I feel like this is becoming less of a recommendation, and or maybe it's just because maybe I'm recommending it less because my personal experience was, I found that exhausting. So I would go to the community pool that was, right down the street from me, and the high school swim team was practicing there in the evening in the hours that worked for me. So they would have to, this was just the policy, you know, the high school team could use all the lanes unless someone from the community showed up. So I would like waddle in there with my big pregnant belly, and they would shut down a lane. And then I would just do handstands and things, different positional exercises in the water. And again, it sounds so benign, but if you like hold your breath and dunk yourself and do all these positions until you need to take a breath, and you come up, you take a breath and you dunk yourself, and you do that for like 40 minutes, it's very exhausting, especially in pregnancy. I kind of felt like I was lightly waterboarding myself. And then, and I also found it, you know, I'm usually not a very self-conscious person, but it was like a little bit awkward. I remember one day I was like, I'm just gonna like explain it. I bet once I explain this, these kids, you know, they just need to understand. So I like waddled over to the lifeguard who was also in high school, and I was like, hey, you must wonder why I'm here. I just want to tell you, like, my baby is upside down, so I'm doing this stuff. I'm gonna try to, and this kid looked at me like, this woman is even crazier than we thought. And so I, you know, I always felt like, I think there's, I think, I don't know because we don't have any research on this, but I think that the exercises that use gravity, as in out of water, where you're using gravity more and putting a little more sort of tension on the ligaments and the muscles when you're stretching, I just feel like those are more effective. So I tend to steer people more toward the spinning babies positional exercises and less toward the pool. But again, that's also because like the pool is just, you know, it's so many more steps for someone to get there, and not everyone has access to a pool and dry off and work with the full schedule. I don't know. It was like the straw that broke the camel's back.
Yeah. It's good to make people feel like they don't have to go to a pool either, because that can feel like a whole other more pressure. You know, some people love the pool and they love to know that that's an additional activity they can do while they're in the pool.
Absolutely.
But to feel pressure that they have to go to a pool now because it's one of the things they're supposed to do, that's also hard.
Right. So. Right, exactly.
Yeah, these are all like recommendations that everybody has the right to choose what works best for them, their body, their baby, their schedule. You definitely, I don't want anybody to feel like, you know, their care provider would think less of them for not trying all of these things. But I know personally for me, I was lucky in the fact that none of my babies were ever breech, but I know that my personality is one that if I had needed a cesarean, for example, which was not something that I desired, I personally would want to feel like I did everything possible. I didn't want to have any regrets. Not that anybody should have regrets, but if that's your personality, knowing that there are lots of things that you can try, if that brings you peace of mind that you tried it all, there's, you know, lots to try. If you're somebody that's like, you know what, I'm going to pick one or two of those things that works the best for me, but otherwise I'm at peace with needing a cesarean, that is also completely reasonable and fine. You know, it depends on what type of personality you have for sure. And that's the best part. It's your choice, your body, your choice.
Yeah. The one thing I wanted to add too is that sometimes people go, like say someone's pregnant, their baby's breech, they go to their care provider and they say, I'm going to try these things. And their care provider may say, oh, that sounds good. Go for it. Have fun. Or their care provider may say, oh, no, that doesn't sound like a good idea. Or there's no evidence that that works. Or that could actually be dangerous. When in most of the cases where they're saying that could be dangerous, they actually don't have any evidence that it could be dangerous. Or they're ignorant and they don't know anything about the thing that actually could have really high results of positive outcomes. But it's not in their wheelhouse because they're not a doctor of Chinese medicine or they're not a chiropractor. And so they don't know. But meanwhile, they're the kind of person as a provider that's going to go, well, if I don't know about it, I'm going to tell you not to do it. And I always find that challenging as a doula and a childbirth educator of like, okay, these people have been practicing a long time. Chinese medicine's been around for 3,000 years. Chiropractors go to medical school. Like, it's just, there's a lot that is good out there, but your provider may not know about it. So investigating it as a grown-up to say, I'm going to investigate this and decide whether it's safe for me to do in the first place. And if it is, then I'll tell my care provider later that I chose to do it anyway, you know, and maybe that will help them with their future patients.
Yeah.
How did your husband support you during this time doing all these crazy things?
Yeah, he was great. I'm trying to think. I mean, he was very supportive of, I think in general, he was, a lot of partners are like this. They're sort of like, you know, they're there to support you, but then ultimately he was like, you know, but I want you to have the final decision on this. And so it was interesting that oftentimes he would, you know, we would have a conversation, and he was a fantastic sounding board, and he would ask good questions, and we would think back and forth, and then he would, you know, but ultimately the decision was, he just wanted to make sure that I felt like it was my decision. And so then based on my training and my personal preferences, I would, you know, sort of make a decision with his input. My husband himself is a researcher and a scientist, and he's the most gifted researcher I've ever encountered. And I have just, I mean, even in the last 5 years, I am blown away with what he's shown me of his capabilities. But back then, 5 years ago, so we would have a conversation and then talk about it, and then I would sort of tell him what I thought was the right decision. And then as part of his own process, he would need to, on his own time, just dig into the research and delve deep. And then I found it really reassuring and comforting that he would come back to me and he would be enthusiastic, like showing me all of these studies and all of it, and, you know, new studies that I hadn't seen yet, and all these things. It's like, this is definitely the right decision. So that felt like a comforting, reassuring support, that he, you know, I felt like he really had my back. And then he also did all of the wonderful things that all partners do, or all partners can do, which is, you know, just helping with all of the detritus of life, you know, the tasks that had to get done, you know, just chipping in a lot with stuff around the house, and helping do a lot of processing and talking, and you know, little things like back rubs. And yeah, he was fantastic through the whole thing.
Yeah. That's good to hear.
What was that? Research, and it's
good to hear.
Yeah.
Oh, sorry, the sound cut out. Just as you're complimenting my husband.
So I understand you also had 2 external cephalic version attempts. And so can you tell our listeners what exactly a version is?
Yeah. So a version is when you have a trained provider, and sometimes an assistant as well, use their hands to just sort of press strategically on the outside of your abdomen to encourage the baby to rotate, or to, you know, to physically rotate the baby. Before they begin, they feel the position of the baby with their hands, and they also look at the position of the baby with ultrasound, and they make a plan based on that baby's position and how its arms and legs are tucked, and anything else that they see, make a plan for how they'll rotate the baby. Some babies move very easily, and some babies require quite strong movements in order for them to move, and some babies just don't move. And the baby's heart rate is checked periodically throughout that process as well. And I should say also, I'll just sort of pause and say I was pretty determined to get my baby to turn, because that was the right decision for me and my family. And of course, there are a million factors that go into that decision for each person. One significant factor for me was it was my first baby, and we knew we wanted to have more children. So I really wanted to avoid a cesarean birth if there was a safe alternative. And I knew even then, you know, and then if I had a C-section, I would like to avoid a repeat C-section if possible, because we were planning more children. But it's a very personal decision. And so I was very glad I tried the 2 versions. But it's a decision that each family has to make for themselves.
One question I have about that, I was fortunate to attend 2 external versions on the same person as a doula. And being a doula over the years with clients who might have had breech babies, and many of this was years ago before I knew more. But it seemed like some, and I still hear this occasionally, it seems like there are some providers who are not comfortable with doing external versions. And so they'll tell someone, no, we don't do that. But then there are other providers that seem to do them all the time and are well known for being open to doing them. So how, if somebody's with a provider that says, I don't do those, you know, or they're not really that successful, or I'm interested in that, let's just plan your C-section, where can they go from there?
Yeah, that's a great point. I think a lot of it will depend with what kind of practice that person is practicing in. So if the patient can say to the provider, you know, okay, well, if you don't do them, is there someone else in this practice that does? Or even look in their community to see, you know, sometimes it's tricky with insurance coverage, or if you've gotten most of your prenatal care in one place. But I think, you know, providers are human. And so if someone has had a negative experience, or someone has had, the poor outcomes are so rare with versions, so rare. But if someone has had one of those very rare, very sort of shaking, you know, because it's so unexpected, if they're really shaken by one negative experience in their own career, then that may influence their counseling moving forward. And so I think that it's fair for a pregnant person to do the research, to know that they're generally low risk, and then to pursue that option with someone else if they'd like that. And then to also keep in mind, they're only mildly successful. The success rate is a little more than 50%. And a lot of that also varies from provider to provider. So when I booked, I had an advantage. I was working at that hospital in a practice, so I knew the stats of all of the obstetricians in that practice, and I booked with someone with a good success rate. I think it's okay to sort of ask, you know, like, is this something you generally feel comfortable about? Do you go into it feeling like, you know, a little more than half of the time they're successful? Like, do you feel like you can do this well? And if not, is there someone in the practice who's really known for just having that feel, that sort of magical hand touch feel, to get it, you know, to get to work more often than not?
But also, I like to think of statistics in a different way too. Like, some people look at 50% as that's 50-50. And other people are like, yeah, there's a 50% chance it'll work.
Mm-hmm.
Right?
Mm-hmm.
You know, like, some people are like, there's a 10% chance, I'm going to go for it. And others are like, man, 90% chance I'll fail, forget it. So it's like, depends on your attitude about it too. Because if you're one of the people that's successful, even if it's a 1%, that's really awesome. But some people look at 1% as not worth it at all. And then there's also the turn of it, where people say there's a 1% risk of something bad happening, and they say, then I'm not going to do it because there's a 1% risk, right? So it's interesting how we play with statistics in our head.
Right, and also sort of what the risk is. So in this case, you know, the risk of failure would be that the baby was still breech. So it's like, well, I'm right where I started. I don't really see that as a big problem, as opposed to, you know, if the risk was like, oh, and then there's a significant risk that you're going to have a big drop in the baby's heart rate. You know, there is an extremely small risk of that, and that's why we monitor the baby's heart rate through the procedure. But it's small. So you know, you just sort of also weigh what the risk is and what risks you're willing to take on. I agree completely. Well put. Yeah.
Yeah, and as this is a theme that keeps coming up in our podcasts, but that you got to tell both sides of the story. And so if your provider is somebody who says, you know, well, your baby is breech, and so we have to schedule a cesarean, and you ask about any other options, and they say, yeah, well, we could try a version, but there's risk to that. But then they don't also say about the risks to a cesarean, because although C-sections are safer than they've ever been, meaning at any other point in history, we have modern anesthesia, modern intubation techniques, we have sterile technique, we have, you know, decades of research on best practice. And so, yes, you know, when someone has to have a cesarean, as a childbirth educator, I want to reassure them that cesareans are safer than they've ever been. But that doesn't mean that they don't have risks. C-sections have different risks than vaginal deliveries, and sometimes they have greater risks than vaginal deliveries for mom and baby. For example, there's going to be an increased blood loss, for example, with a cesarean than generally with a vaginal delivery. You have higher rates of, you know, post-delivery infection, for example, greater chance of having a post-operative blood clot, right? They might still be small, but they are real. And so I don't think it's fair for a provider to say, well, we don't do versions because there are risks to versions, without ever actually telling you what the risk is to a cesarean birth. So know that as a pregnant person, as we've been discussing, you have the right to a second opinion. And so as Kate has described, like asking, well, is there anybody else in this practice or anybody else that delivers at that hospital, at our hospital, that you know does versions, and then book an appointment with them to have a second opinion. Because if somebody says, I mean, we can try, right? That's a lot different than someone who's like, yeah, let's try. So you have the right to seek out that if you desire.
Yeah.
Okay, so we're talking about version, and so let's talk a little bit about the statistics. And these are from evidencebasedbirth.com, which I highly recommend. So we've talked a little bit about risks of version, and the most common risk is a temporary change in the infant's heart rate, which is a 4.7% chance. And serious complications, as Kate said, can occur. The most recent statistics we have is a 0.24% chance. That's 1/4%. The CDC data, the most recent CDC data on versions is from 2016. And in that year, about 11,000 people went under a version procedure. And 55.8% of those versions were successful at turning the baby head down. But then the question is, did those people go on to deliver vaginally? Because they can turn your baby head down, but just like any pregnancy, your pregnancy could still result in a cesarean birth for a number of reasons, that the labor doesn't progress, or the baby gets into a difficult, head position to, be pushed out, or baby goes into distress or whatnot. So of the successful versions, about 68%, so more 4,200 people went on to have a spontaneous vaginal birth. And on the other hand, the 44% were failed versions, which means that the baby did not turn. And the majority of those people went on to have cesarean births, which was 88.2%. So that's a pretty big amount of people that we have that most recent study on. So just wanted to point that out. And then Kate, would you mind telling us a little bit about what it's like to experience a version? Because this is one thing I hear a lot of myths on as a labor and delivery nurse, not only from parents, but from other nurses that do not have experience with attending or assisting a provider during a version. Meaning, I've had the privilege, because I worked at that hospital in Cambridge with you, of actually attending quite a few versions. There's a number of providers there that do them. But nurses that I've worked with in the past who don't have experience, like, oh, it's excruciatingly painful. People feel like they're being murdered, like they can't possibly, you couldn't possibly want to ever undergo something like that. And I've heard similar things from parents, and although it certainly is not a day at the spa to have somebody push on your belly to try to get your baby to turn. We all know how uncomfortable it is in general when the baby starts to do baby aerobics in your belly. Can you tell us about what it was like in your experience to have your version?
Sure. Okay, so yeah, I mean it's definitely uncomfortable, but it's not intolerable. And I think the important thing is that it's not like labor when you can beg the next contraction not to come, but it will still come. This is, you can tell the providers to stop at any point. So you're completely in control. And you can also say, I just need a 1-minute break to catch my breath. I think that if it's looking like a torture chamber, then there's something not right with the vibe in the room. So I will say, I mean, it was definitely uncomfortable. I breathed through it. I was sore and I was discouraged afterward. And I was actually even a little bit lightly bruised later that afternoon. And that's just because of that very hard, deep pushing to try to get the baby to turn. It was definitely tolerable. And I did feel like, I knew I was in control, and I could have told them to stop at any point in time. But I was fine with all of the attempts that were made. I wanted, this was like a temporary thing. The pushing was maybe a total of, like, we really went for it with that first version. I'd say maybe it was like a total of 10 minutes spread out over maybe 15 minutes total. It's hard to exactly remember, but it's a temporary thing with trying to push in different spots. It's not like they're not like hitting you. They like gently place their hands on your belly and then slowly increase the pressure in that spot.
Yeah, it's not like there's CPR in your belly, right? It's not.
No.
The way it might look, if you imagine it, is imagine that someone is putting their hands on the opposite side of your belly from where they're standing, and they're putting a firm but sustained pressure. They're trying to really flip that baby. And while it might be uncomfortable and they might be using some of their strength to do that, it's not like being like pushed or hit while it's happening. They're not shoving the baby.
Right, exactly. It's steady, and they're trying, because they're trying to gently get the baby to turn, to do a somersault. Yeah, it was, so I was fine with it. It was actually hardest on my husband. He was there in the room to support me, and he did not like it one bit. My funny story is that the obstetrician I saw for my first version is actually the head of the OBGYN department where I work. And I had my version in the morning, and then that same night was the big holiday party for the OBGYN department at work. So at that party, the department head always stands up and he tells extremely corny jokes. It's just part of his tradition. And so I just remember watching my husband at the holiday party just like shake his head in disgust. Because here he was watching this guy, like from his perspective, he felt like he'd watched this guy abuse me earlier that day. And hearing the mic telling cheesy jokes. I can still picture his face just like, who do you think you are? But luckily they're all patched up, and I was like, I don't worry, I consented to that version. Yeah.
Don't they also give medicine to relax the uterus, and that can help with that? Does that still happen?
Yes. So we used terbutaline, which relaxes the uterine muscle. I'm glad you brought that up. I was really surprised by the side effects of the terbutaline. Even though academically I knew what to expect, it still just caught me off guard the first time. I think it turns out I'm also very sensitive to terb. So I was instantly just very shaky and jittery, and my heart was racing. And it basically felt like I had had way too much coffee to drink, but like instantly you're like, whoa. And so in some ways it was a helpful distraction for me to just kind of try to focus on steadying my hands during the version. I was just like, just gonna try to take good slow deep breaths and get my hands to stop shaking. But I think, I always tell patients before, I had a pretty pronounced reaction to it, but anytime I give it either in labor or before a version, I just tell them this is a known side effect, because if you know that ahead of time, it's a lot less alarming to then feel jittery than if it just kind of catches you off guard. Yeah. And then I think, so there's other options too. Some places may use a spinal or epidural anesthesia to further create relaxation. That wasn't something we did because for two factors. They tried and they felt like the resistance they were encountering was not from abdominal tension. You can tell when you feel someone's abdomen if it's abdominal muscles that are contracting, usually involuntarily, just from that pressure and kind of resisting. And that's not what they felt they were encountering. And also, I wanted to remain open to the possibility of a vaginal breech delivery. And the provider at that hospital, at that time, anesthesia didn't want to have an epidural placed too close to when another epidural might be needed. And we knew we might want that tool for vaginal breech birth. Yeah. Oh, and one other option that's used now is nitrous oxide, which at the time we did not have that available at that hospital, but that can be another great tool to just kind of help, just sort of help everything relax. And also my experience with nitrous oxide later with my second birth in labor was it just kind of makes you not care about sensations. That was my experience. So you're just kind of like, yeah, keep going. Like, I truly don't care.
Oh.
I'm glad you brought up, Kate, that you, when they did the version, they didn't feel like the resistance they was getting was because you were too tense. Because sometimes that is the case. So I have a friend actually who her first birth was an unmedicated vaginal delivery, and her second baby was Breech. And so she had a strong desire to not have a cesarean because she had already had a successful vaginal delivery, and she was a great candidate for aversion because she had her belly had already been stretched out before, and so she was a good candidate. But the provider that she went to, it was a big academic center, they were not really supportive of her having aversion. I was her doula, and so she consulted me and asked about options, and I was the one that even told her about it. They were just gonna schedule a cesarean, so she did her research and brought it to her provider, and they were like, I don't know why you wouldn't just want to pick the baby's birthday. You've already got a kid at home. Like, they were, why make it complicated for yourself? They were kind of dismissive. But she persisted, and she got somebody to attempt the version. But during the version procedure for her, she found it very painful, and she could not relax. And she was disappointed because she had them stop. She doesn't feel like they really even got a chance to try to turn the baby because she was very scared and nervous about the pain. And so they were like, well, this version didn't work, but they didn't actually really even get a good try in. And so I talked to her about it. I said, the research does show that some providers will do an epidural if the problem is that they can't even try because you are nervous or scared or in pain. There are some places who will do it with an epidural. And so she brought that to her provider, and they were like, no, we don't do that. And she was like, well, can we try? And they were like, no. And she's like, well, you do an epidural for people in labor. Why can't you do it for me with a version? And they were just like, no, we don't do that. So she actually, at 38 weeks of pregnancy, changed her provider and found a provider who would do this version for her. And what's great is that she brought this provider, she actually went to this provider to discuss vaginal breech. She wanted to find someone to at least have a consultation about it who did vaginal breech instead of someone who did not do vaginal breech consulting her. She wanted to consult with someone who did. And so he actually brought up, like, well, we could try another version attempt. We could just do it with an epidural. And she was like, oh my God, that's what Melissa said. So we did, and it was successful. And she ended up having an unmedicated delivery with her second baby, who actually was 2 pounds bigger than her first baby, an unmedicated vaginal birth. But what was funny is she was hesitant about the epidural because she had had an unmedicated vaginal delivery with her first because she didn't want to have an epidural. And so I was talking to her about it. I said, well, think of it this way. When you're in labor, that pain is a normal, healthy pain, right? We talk about pain in labor in childbirth class, and it's normal. It doesn't mean that anything's wrong. There's no pathology. There's no disease. The uterus contracting has never killed anybody, right? Like, the pain of a contraction has never killed anybody. But the version procedure, they're pushing on your belly. That's not the same thing as a labor contraction. They are causing some discomfort to you because they are pushing on you. And so, think about it as like just taking pain medication for something else that, is causing you pain and discomfort. And she's like, well, when you say it like that, it makes a lot of sense. I will get this pain medication for a procedure that I'm having, even though, like, I don't choose to have that pain medication for my labor experience. So I just wanted to throw that out there. Yeah. But you went on to have a second version attempt. After, trying, you felt like it was a good try. Yeah. You had to keep doing it. So tell us about why you made that decision.
I want to just, if it's okay, I want to back up and add one other option, which is, so typically we book versions. If we know a baby is breech, we want to book a version on the early side. So pretty much 37 weeks and 0 days, or 37 weeks and just a few days if possible. And certainly if the breech is not discovered until later on, by all means, it can be later, or if there's some reason why, you can do it at 38 weeks, 39 weeks, 40 weeks. But another option would be if the baby is breech, you can book a trial version that could go into a C-section if unsuccessful after 39 weeks and do the whole thing under spinal. So the patient is moved to the OR, given spinal anesthesia. They try the version there, and spinal is very dense anesthesia where patients do not feel the version attempt. And if it's successful, then they wheel you back to a labor room. Well, you have a few options. You could go home with a binder and await spontaneous labor. Or at that point, you're 39 weeks and you know the baby is head down. So you could be moved to a labor and delivery room and begin an induction of labor. Obviously, there's pros and cons to both of those. And then if it's unsuccessful, then progress using that same spinal anesthesia, progress to having a C-section right there. Yeah, sorry. Okay, so yeah, I apologize. Let's see. You said
no, that was a great point. I'm glad you said that, because there's lots of options, right? And there's pros and cons to all of those options, and you should be you have the right to be counseled on all of those options. And if somebody's saying, well, that's just not what we do, if you're listening, you know that it is done somewhere. And so it's totally within your right to seek out a second opinion of somebody that does do that. It doesn't make much sense, asking someone who doesn't perform a version attempt to counsel you on the risks and benefits of a version is not going to be the same consultation as someone who does practice versions and can counsel you on pros, cons, risk, benefits. So thank you for adding those other options as well. Like you said, hey, if you're going to have a spinal and a cesarean anyway, and you're 39 weeks, might as well give it a shot while you're there. It's definitely something to keep in mind.
Yeah. So then I'm sorry, you'll have to repeat the question you had asked before I backed up.
Sorry. I was going to say, you had a version attempt the first time that you felt they tried their very best. You had like the chief doing it for you. So what was your thought process behind like trying again, or when did you do that?
Yeah. The thought process was basically I just wanted to try everything possible. I think it relates to part of what you referenced earlier, that mindset of like, if I'm going to have a C-section, I want to just know that I've tried everything. And then I thought, certainly babies move and rotate and they get into different positions, or they tuck their chin a little differently. So you give the baby another week to just be in a slightly different position when you try a version again. And sometimes, sometimes it will be successful. And then I booked with a different provider, also thinking, just sort of everyone has their own techniques. And so sometimes hand skills from one person will work a little bit better on one body type than on another. And so, it was felt that it was a safe decision, and my baby had tolerated it very well. I think it would have been a different decision. Let's say when I had the first version, if there had been a decel in the heart rate and we thought like, oh, maybe there's a cord that's tightly wrapped somewhere. If there had been something that seemed a little like, oh, I don't know, then I would have had some reservations. But the baby was rock solid through the whole thing. And so I was like, I want to try everything. And so tried another one, which was also unsuccessful. I know in the week between the first and the second, I had done a lot. I really delved into the reading. So I showed up with an extremely full bladder for the second version, and I had her try with a very full bladder that would, in theory, lift the baby's bottom as high as possible in my pelvis, and that didn't work. And so then I was like, all right, pause. Now I'm going to go empty my bladder, and I want you to try again. She tried again. It still didn't work.
Can I say, as someone who has been pregnant 3 times, for you to have tolerated someone pushing on your belly with a full bladder, I give you major props. Like, I think that's pretty badass.
Well, Alyssa, you're a nurse. Think of what you do with a very full bladder for hours on end. Come on.
Oh, man. You had, the other thing that you had mentioned when you were talking about deciding whether or not to try with an epidural, you mentioned vaginal breech. The hospital that you ended up having your daughter at is one of the only hospitals left in the state where there are still providers who will do vaginal breech deliveries or have the skill set to do so. Is that something you had considered? Why or why not? Do you have anything to say about that?
Yeah, definitely. Yes, I did consider it. So in fact, the second version was done by a private practice OBGYN who is an extremely experienced breech birth provider. I believe we have four of the doctors in our practice are comfortable. Maybe five. I have to do the mental count in my head, but who are comfortable with it and under certain parameters, very carefully defined with good counseling, open to providing them, but they're part of a large practice and there's no guarantee about who would be on call or who wouldn't be on call. So I transferred my care to this, the OBGYN who's in private practice, because she covers all of her patients 24/7, which is also very rare today. And so I transferred to her at about 38 weeks, so right at the very end of pregnancy, in the hopes of having a vaginal breech birth. And so that was a very complex decision for me. The research shows that with a trained, experienced provider, breech birth is safe. And so many of the misconceptions and controversies about breech birth that we have today stem from the fact that many young obstetricians have not typically been trained in breech birth. And so we do know that breech birth with an untrained or inexperienced provider does have risks. So most American women are counseled to have a cesarean birth if their baby is breech. And I think that since so many hospitals simply recommend cesarean across the board for breech, because that is the safest option with their existing resources, that makes some birth professionals skeptical of the safety of breech birth elsewhere. But I mean, ultimately, I knew I had no guarantees about my labor or my birth. And I mean, really no one ever does, right? And I knew I was in excellent, skilled hands with this OB. And my husband did a ton of research, of course, and he completely agreed with me. And once I had made my decision to attempt a vaginal breech birth, I got, of course, a flurry of unsolicited advice from a variety of folks, or even just kind of odd comments. Like someone would say, like, "Oh, I have a friend who works in L&D, and they say they never do breech births at their hospital." And so it would have been exhausting to review the research with everyone and explain why it might be best to have a breech birth by cesarean in some places, but also to reassure them that this was an informed and safe decision based on, you know, my hospital and my provider. So I just had to stop discussing it altogether at the end of pregnancy. But I think that is a key part of the research we have right now, is that it's about having a trained, experienced provider, which those are common in some parts of the world, and they're not common in the United States. Yeah.
All right. Well, I think that's a great place to end episode 11, part 1 of our conversation with Kate Damon today. I'm hoping I'm keeping you on the edge of your seat. Like, what happens next? Does she go into labor? Does she have vaginal breech birth? What's going on? Let's talk to Kate in part 2, episode 12, about her first birth experience. We hope you will join us for that episode.